So today we're going to talk about aortic dissections. So aortic dissections are a very rare but a really catastrophic disorder. So it's associated with a really high mortality. So many patients even die before reaching the emergency department. And patients that have a chronic aortic dissection, that's more than 2 weeks, have a slightly better prognosis. But anyway, if left untreated, the mortality approaches about 50% in the first 48 hours of onset. So, despite having a wealth of literature, a significant number of aortic dissections are missed in the emergency department. We must first understand that blood vessels, both the arteries and the veins, consist of three layers. We have the intima, the media, and the adventitia. In the particular case of the arteries, the tunica media is more rigid and thicker in order to withstand the pressure injected by the left ventricle. So that's why they're bouncy and thicky. So an aortic dissection is where part of the tunica intima, which is the endothelial or the most innermost layer of the blood vessel of the aorta, is basically ripped off. So what happens is a tear in the tunica intima of the aorta forms, and the high pressure blood flowing through the aorta begins to tunnel between the tunica intima and the tunica media. So it separates the two layers. Now, as the high pressure blood continues to share more and more of the tunica intima of the tunica media, blood starts to pool between the two layers, increasing the outside diameter of the blood vessel. So the area where the blood collects between the tunica intima and the media is called a false lumen, and the true lumen is the regular lumen of the blood vessel. Since high pressure is a cause of aortic dissection, it's no surprise that the aorta is the prime target of this problem. What causes aortic dissections? Well, chronic hypertension is the major cause, whether it's caused by stress or from increased blood plasma volume like in pregnancy. Also, we can have it from blood vessel coarctation, which is the narrowing of the blood vessel. That can also cause dissection. There are two main anatomic classifications used to classify aortic dissection. The first one is the Stanford system, which is more frequently employed. It classifies dissection into two types based on whether ascending or descending part of the aorta is involved. The type A involves the ascending aorta, regardless of the site of the primary intimal tear. So it just has to happen in the ascending part. Type A dissection is defined as a dissection proximal to the brachiocephalic artery. Type B aortic dissection originating distal to the left subclavian artery and involving only the descending aorta, so just the descending part. The second one system we use is the DeBakey classification, that is based upon the site of origin of the dissection. So the type 1 originates in the ascending aorta to at least the aortic arch, so just a little part. We have the type 2 that originates in and is limited to the ascending aorta. The type 3 begins in the descending aorta and extends distally above the diaphragm. That's the type 3A, or below the diaphragm, that's 3B. And ascending aortic dissections are almost twice as common as descending dissections. In order to an aortic dissection to occur, an underlying condition usually has to exist that weakens the aorta's wall. Connective tissue disorders like Marfan's or Ehlers-Danlos syndrome can cause a dissection, as well as decreased blood flow to the vasa vasorum. Aneurysms can be a cause of aortic dissection, as well as incidental dissection can also cause aneurysms, because again, that dissection weakens the blood vessel wall. So in other words, weak walls can lead to an outpouching of the blood vessel or a break in the tunica intima, and both of these weaken the walls further. Aortic dissections cause a whole bunch of other problems too. A lot of complications are related to where the blood in the false lumen flows. The blood could flow back up to the aorta, to the heart, and enter the heart's pericardial space, filling it with blood and causing a pericardial tamponade, which is a really, really bad and potentially fatal situation. So the blood flowing through the false lumen could also puncture a hole through the tunica media and tunica externa and bleed into the mediastinum, which could kill you very fast. because that's a lot of blood leaving the vascular system really quickly. The tunneling blood could also puncture a hole in the tunica intima and return into the true lumen. Yet another possibility is that the blood could continue to tunnel between the tunica intima and tunica media until it reaches another artery that branches off the aorta, like the renal arteries or the subclavian arteries. The blood and the false lumen can put pressure in these branching arteries, decreasing the blood flow to the kidneys and the arms. That causes a whole new mess to deal with. The main symptoms of aortic dissection are sharp chest pains that often radiate to the back. A person also might develop weak pulses in the downstream arteries like the brachial and the femoral arteries. Or sometimes there might be differences in blood pressure between the left and the right arm. An aortic dissection is an emergency because it can lead to hypertension or low blood pressure, as well as shock if there's rupture and significant blood loss. So basically, the patient might die from both a hypovolemic and a cardiogenic shock, which is, well, not great because we don't have enough liquid for the heart to pump, and the heart as a pump doesn't work anymore. On a chest x-ray, there's typically a widened aorta. More sensitive imaging techniques that are commonly used include a transesophageal echocardiogram, which is where an ultrasound probe is passed through the esophagus to obtain a clear picture of the aorta. There's also a CT angiography and a magnetic resonance angiography, both of which look closely to the blood vessels, and we can identify where's the tear or, how big it is. And aortic dissection needs to be treated immediately. Type A aortic dissections are treated surgically, where a surgeon takes as much of the dissected aorta as possible and blocks the entry of blood into the wall of the aorta. The aortic wall is then reconstructed with synthetic graft, and sometimes that graft is propped open with a wires mesh stent to make it big. And type B aortic dissections are treated with beta blockers and nitroprusside, and that's pretty much everything.